Start my talk and can all of you see my slides?
Yes, Parni.
Yes, sir. I will start my talk, sir. It's a 15-minute talk, mainly focusing on preventive measures in dementia. Dementia is an increasing problem as the global population ages. All of us know that. Alzheimer's disease is the most common form of dementia in older adults, accounting for 60 to 80% of cases. Asymptomatic individuals often present with concerns about developing dementia, especially when they have a family history. So you may be seeing in the practice that people coming to the clinic, when someone in the family has some dementia, doctor, I'm very worried that whether I will develop dementia and how to prevent getting dementia. So nowadays, in every field, every specialty, we are talking about preventive measures. Even though the treatment options are available, the important focus in every specialty now is the preventive measures all over the world. Two major reports released in 2017 review the literature on potentially modifiable risk factors for dementia and highlight strengths and weaknesses in the available data to support the impact of risk factor modification on dementia incidence. There are a lot of data available. The overall incidence is of low quality and does not support any single intervention as effective in delaying or preventing dementia. There are so many factors people are focusing and modifying the risk factors, and they are not able to pinpoint a single factor as the preventive aspect of dementia, because you need more of a multifocal modifiable factors. There is optimism that intensive risk factor modification, especially during midlife, age 45 to 65 years, has the potential to delay or prevent a substantial number of dementia cases worldwide. In support of this, large population-based studies indicate that the incidence of dementia has declined in high-income countries over the last several decades. It's the incidence decline, still a lot of cases are there. They are because there is some reduction in the some other factors made some difference in the incidence of dementia in the developed nations. Observational evidence supports an inverse association between various components of the healthy lifestyle and the incidence of dementia. The healthy lifestyle they're focusing are on social interaction, education, and mental activities and physical exercise. All of us know that a lot of problem with this factor which I was talking. Because of electronic world, the social interaction is coming down. And education, obviously we are getting educated, but there are a lot of stress component in the education and mental activities. What mental activity is not focusing on to only one aspect of mental activity. It is having a mental activity in every aspect. And physical exercise. We know that there are people giving a lot of importance to physical exercise, but a quite large population is not doing adequate exercise. So a very, very important factor like social interaction, education, mental activities, and physical exercise. So the component of healthy lifestyle and the incidence of dementia, there is some correlation. It is not known whether these interventions effectively reduce dementia risk. Most trials have looked at relatively short-term interventions and outcomes. So you need to have a long-term follow-up and multi-factors, modifiable risk factors we have to look into. Single factor for a short-term data, you have to look very carefully because you may not give any significant outcome. Numerous observational studies have found an inverse association between physical exercise and risk of dementia. The protective effects of exercise remain unproven. Possible that physical exercise has synergistic benefits as part of a more comprehensive risk factor reduction strategy. Meta-analysis of 12 randomized trials, aerobic exercise in healthy older adults did not improve cognitive outcomes in any domain, even in trials in which cardiorespiratory fitness improved in the exercise group. The duration of the trials ranged from 2 to 6 months' time. Two trials of more prolonged and intensive lifestyle interventions in sedentary older adults and adults with type 2 diabetes also found no improvement in cognitive function or rates of cognitive decline and dementia. But you have to keep in mind when you're having a large data, meta-analytic data, that the outcome may not be directly applicable to a single individual. But this factor as together overall has some benefit. Prospective cohort study that began following exercise levels in healthy adults between 35 and 55 years of age failed to find a productive effect of exercise over nearly 30 years of follow-up. Patients diagnosed with dementia, exercise level began to decline up to 9 years before the diagnosis. Those who are going to develop dementia, they start slowing down they may lose interest in things. They may not doing exercise like what they used to do before. So they found there is a decline up to 9 years before the diagnosis, suggesting that reverse causation may partially explain previous observations that exercise is associated with a lower risk of dementia. Cognitive training. There is no evidence to support that computerized brain training programs marketed commercially, most of which are not as intensive as the intervention in the active trial, have benefits beyond short-term gains in the specific cognitive tasks that are being rehearsed. Advanced education is believed to represent a higher cognitive reserve that decreases the impact of degenerative pathology on cognitive function, rather than providing a protective effect against the accumulation of amyloid or other pathologic changes. So what does it mean is advanced education gives a higher amount of cognitive reserves that has a protective effect. Once clinical dementia develops, patients with higher education or occupation levels appears to experience a more rapid cognitive decline, at least in part because they are assumed to have accumulated a greater degree of Alzheimer's pathology by the time dementia is apparent, compared with those with less education. So they may sustain it for longer time, but once they start declining, they decline rapidly because the cognitive reserve is no more, and the brain is having quite large amount of load of amyloid plaques. Epidemiologic studies offer optimism that multimodality risk factor reduction is worthwhile, not just for cardiovascular outcomes, but also for cognitive health. So as I was telling repeatedly that multimodality risk factor reduction is very, very important. We have to look into multiple domain, not single domain. Lowering the prevalence of hypertension by 25% could reduce the incidence of Alzheimer's disease by nearly 100,000 cases. American Heart Association and American Stroke Association concluded that blood pressure lowering to lower the risk of post-stroke dementia is effective, and it is reasonable to lower blood pressure in midlife to lower the risk of late-life dementia. So it's better to pick up the blood pressure early, and if we start reducing blood pressure from the early time of diagnosis, that has a more impact on the cognitive outcome. The potential benefits of fish oil consumption and the risk of dementia have been studied extensively in observational studies. Findings are mixed. Many longitudinal cohort studies have shown an association between higher fish oil consumption and reduced risk of dementia, cognitive decline, and accumulation of white matter abnormalities on brain MRI. Benefit may vary according to apolipoprotein E, ApoE genotype, with epsilon 4 carriers deriving more benefit from fish consumption than non-carriers. So this has a protective effect. Meta-analysis of 3 trials found no effect of treatment after 6 to 40 months of supplementation. The Mediterranean diet, famous diet which people are talking about, there is no single Mediterranean diet. It is high in fruits, vegetables, whole grains, beans, nuts, seeds, and include olive oil as an important source of fat. Low to moderate amount of fish, poultry, dairy products, and there is little red meat. One large randomized trial, that is PREDIMED, has suggested that adherence to a Mediterranean diet improves cardiovascular outcomes, including stroke, and it may directly or indirectly promote lower dementia risk. B6, B12, folate. Some evidence that elevated serum homocysteine and or low serum levels of folate, vitamin B6 and B12 may be associated with impaired cognition and risk of dementia. We know B12 deficiency produces cognitive problem, and the other vitamin has a role in homocysteine, and they found that elevated homocysteine can have impact on the cognition. There is no convincing evidence that vitamin supplementation prevents dementia. There is some evidence that vitamin D deficiency is associated with cognitive impairment in older adults. The effect appears to be small and of uncertain clinical significance. If you take the statins, several large retrospective studies, statins use has been associated with the reduced risk of dementia, that is relative risk reduction by 15 to 40%. Direct association between amyloid processing and cholesterol in the brain is the reason. Statins reduce amyloid burden by promoting the non-amyloidogenic alpha secretase pathway of amyloid precursor protein metabolism and decreasing the inflammation. Indirect effect via decreasing the risk of stroke, since even small cerebral infarcts worsen severity of Alzheimer's disease. So it is a very small talk, but the important thing is we have to keep in mind we live longer. So we need to focus on multiple domains, multimodality factor risk factor reduction rather than a single risk factor. I think altogether, a physical exercise, balanced diet, and stress-free life, a good sleep at night, and reducing all the risk factors, especially vascular risk factors, if we have, and manageable cognitive decline. All those things are very, very important to prevent the dementia or postpone the dementia to a significant level. Thank you very much for listening to me. Thanks once again. I have finished my talk, sir.